Hello, my name is Quentin Davis. I'm the Vice President of Operations at LKC Technologies, and I lead kind of the R&D efforts on the for LKC. And today I'm going to talk about diabetic retinopathy detection using the RETeval device, and in particular, the DR assessment protocol. So an outline of the talk, first I'm going to just describe briefly why I think that better detection of diabetic retinopathy can help reduce blindness, because that's kind of the key feature for diabetic retinopathy, is to try to reduce blindness. Then the second is to review the clinical evidence for the RETeval device in detecting diabetic retinopathy, and then describe the changes in reporting for the new firmware version that we're releasing this month, and then practical issues in using and interpreting results using that DR assessment protocol. So first, diabetic retinopathy is a worldwide health crisis. It's the #1 cause of working age blindness. That's ages 20 to 70. And 1/3 of all diabetics experience some form of vision loss. And 1 in every 10 healthcare dollars in the US is spent in diabetes. And a lot of that is on anti-VEGF and other treatments for diabetic retinopathy. But treatments do exist. Like I said, the anti-VEGF treatments and like laser treatments, there are treatments, but only they really work best for those detected in time. After you bled out, then you have to have a vitrectomy, and that might not work very well. So it's been shown that 90% of future vision loss can be prevented if it's detected early enough. But the current methods to detect diabetic retinopathy are ineffective. How do I know that? I mean, I have some bullet points here, like millions go undiagnosed, 50% of diabetics don't have an annual eye exam, and 1 in 3 have never had an eye exam. But really, this isn't the proof. The proof is the first item, is that it's the #1 cause of working age blindness. If we actually had effective methods to detect it now, it wouldn't be the #1 cause of blindness. And it's the #1 cause of blindness in basically every country except the UK, which has by far the best screening for diabetic retinopathy. And there, they budged it to the #2 cause of working age blindness. So even the best in the world only moved it one place. So, if someone says the system I have works great, refer to item 1. If it's really that great. But anyway, the LKC's RETeval device greatly simplifies the assessment of diabetic retinopathy. And it's new, it's different, it can actually impact the worldwide health crisis. So let's talk about diabetic retinopathy. This is a picture of someone with normal vision, what they would see. If you get diabetic macular edema, kind of everything looks fuzzy. And overnight, you can get diabetic retinopathy to bleed out. You can get these weak blood vessels to break, leaving these large patches of just no vision, of no light perception. And in a recent study, blindness was ranked among the top 4 worst things that could happen to you for all respondents. That's alongside cancer, Alzheimer's, and HIV/AIDS. Anyway, so that's a description of why I think that better detection can reduce blindness. So let's move on to some clinical evidence. First, a little RETeval history. It was launched in 2013, and it was designed specifically for diabetic retinopathy testing by the GP, by the diabetologist, by the endocrinologist, and definitely not least the eye care providers. And if you look at the peer-reviewed publications that use the RETeval device, ending in 2020, there have been 75 overall, 13 of which have been dedicated for diabetic retinopathy. Now, there are other published uses that I'm not going to talk about, but they include glaucoma, retinal vein occlusions, inherited retinal disorders, and mental health disorders like schizophrenia or bipolar disease. So let me show some evidence that the electroretinogram, or ERG, is affected by diabetic retinopathy. This was first published in 1987 by George Bresnik and colleagues, and results have been replicated in basically every continent, and 13 devices using the RETeval device. So here's one example using a RETeval device, where we can go from no diabetic retinopathy to mild non-proliferative to moderate to severe non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. This is what the fundus photographs look like. These are example traces from an ERG waveform. And even if you don't know much about ERGs, you can kind of see that this one looks different than this one. And you should be able to classify those differently than that. Another thing that's affected by diabetic retinopathy is the pupillary response. This was first published in 1992 and has gone through publications through 2020. And these are results from a RETeval device, time over 5 seconds. With a bright light, the pupil diameter kind of gets small and stabilizes. With a dim light, the pupil is bigger. This is someone with normal vision with no vision-threatening diabetic retinopathy. With someone with vision-threatening diabetic retinopathy, the pupil really doesn't change brightness, and this is kind of an 8-fold change in the stimulus, but there's almost no change in the pupil size, unlike someone without retinopathy. So pupil responses are attenuated as diabetic retinopathy gets worse. So these facts were kind of put together in a 2016 publication by Ma et al., where there was developed a DR score that combines kind of an ERG waveforms and pupil response waveforms. And in particular, it looked at the best eyes time to the peak. How long does it take the retina to respond to a light flash? There's kind of multiple light flashes here, here, and here. And also the amplitude, or how strongly the eye is responding to a light flash. Then it also looked at the pupil response, so from a dim to a bright light. If you have an 8-fold increase in the light, how much does that pupil area change? And we looked at the worst eyes pupil response compared to the best eyes ERG. And also these values depended on age, so there's an age correction. And this DR score that combines those 4 elements was developed by William Feuer. He's a biostatistician at Bascom Palmer Eye Institute, the #1 eye hospital in the United States. And he's been an author on when I made this presentation, 481 peer-reviewed journal publications. So let's go over some cross-sectional studies to show that the RETeval DR score compares favorably or changes kind of the same way as increasing retinopathy is determined by photography. So in this paper by Ma et al., DR score is plotted against increasing levels of diabetic retinopathy. And as you can see, as the level of retinopathy increases, so does the DR score. This paper was published, this was done in the United States, this one was done in China. You get kind of the same answer. As the DR score increases, the level of retinopathy is measured by photography increases. And one more cross-sectional study. This one was done in Turkey. This is now showing the sensitivity or the probability of detecting someone with disease versus 1 minus specificity, where specificity is the probability of detecting someone who's healthy. Ideally, in these receiver-operator characteristic curves, if you have a perfect system, you follow this line like this, right on the upper left-hand corner. If you have pure chance, you're kind of a diagonal line in the middle. You can see the RETeval DR score very close to the optimum. In fact, the area under this whole thing is 1. The area of the RETeval device is 95% or 0.95. And these other lines measured in this group were retinal nerve fiber layer thickness as measured by OCT, central macular thickness as detected by OCT, and intraocular pressure. And you can see that all 3 of these measures are only mediocre at detecting diabetic retinopathy or vision-threatening diabetic retinopathy. In a longitudinal study, that was published by Brugel et al. This year or last year. They recorded the DR assessment test by RETeval and photography, the gold standard ETDR 7-field stereo dilated photography. That's 28 photographs of the eyes, and then did nothing with it. Just waited 3 years. Then went back and looked at the charts to see, okay, which of those subjects that we measured had a intervention, an ocular intervention, which had anti-VEGF injections, who needed laser treatment, who needed a vitrectomy. And then this was analyzed by kind of the standard Kaplan-Meier survival statistics and relative risks to compare, well, who did better at predicting who needed an ocular intervention? Was it the RETeval device, or was it the gold standard ETDRS photographs? And here, let me zoom in on kind of the first 2 years, because that's kind of probably the most relevant. What I'm plotting here is the percentage of subjects from the beginning of the test time, beginning when they were recorded, of who needed an ocular intervention from surgery. Now, if you look at the black curve are everybody in the study, independent of any test results. So the study had picked kind of diseased people, actually a wide variety. Some had like no retinopathy, others had proliferative retinopathy. And in 2 years, 10% of all the subjects in the study had an ocular intervention, had surgery. What about ones that had proliferative DR or severe NPDR? Well, 22% of those, as measured by photography, had surgery. What about the RETeval device? With the DR score is greater than or equal to 23.5, 35% had surgery. What about, what about if they had both? If both tests were positive, you had a 50-50 chance of having surgery in the next 2 years. And then, of course, finally, if you had a negative test result, then the negative test results reduced your risk. So you can see here that the RETeval device beat the photography on the positive side, and also RETeval device beat the device on the negative side. You're more healthy on the negative side if RETeval said you're healthy than if the photography did. Just like you're more likely to have an intervention if the RETeval device said you were positive than if the photography said. But of course, if you already have photography, then kind of both positive is really ominous. You can take these slopes of these curves and take the ratio of the slopes, and that's called relative risk. And that's what's plotted down here. So the RETeval DR score's relative risk is 11, which means that if you have diabetes, you get this test, and if it says if you're greater than 23.5, you have an 11-fold increased risk for needing an ocular intervention than if your score was less than 23.5. How did photography do? The same ones I showed here. If you had PDR or severe NPDR, you had 3.5 times increased risk by being positive. What happens if you add clinically significant macular edema? Then you get a little better. You're at 4.2 times. So the RETeval device had the highest relative risk. But how big is a relative risk of 11? Well, I was thinking, what do people know is like, really bad thing to do in terms of health? And I thought smoking. Everybody knows smoking causes lung cancer. Well, what's the relative risk if you're currently smoking and you're female? Well, your relative risk is 8. What happens if you're male and you're currently smoking? Your relative risk is 24 for developing lung cancer. So you can see that this 11 for RETeval, that's roughly the same level of relative risk as you get by smoking for lung cancer. So that's a big relative risk. One more longitudinal study. In this study, the RETeval device, the ETDRS 7-field stereo fundus photographs, OCTA, and fluorescein angiography were used in subjects with moderate NPDR. And they were also measured kind of not only at baseline, but a couple times during the year. Waited 1 year, and then looked at the receiver operator characteristic curves to compare the predictive capabilities of all the tests for who in that year would go from being moderate NPDR to PDR or diabetic macular edema. And let's see how they did. So here is a plot of the area under the ROC curve, where 1 would be kind of perfect prognostication, half is a coin flip. So better prognostic performance is to the right. Who had the best prognostic performance? The RETeval's DR assessment DR score. Who was second? OCTA. Who was third? Photography, because in the levels of moderate NPDR, there were kind of 3 ETDRS levels that was in the inclusion criteria. So which of those 3 did you start at had some predictive capabilities? What about the ultra wide field fluorescein angiography? Not a significant indicator. Okay, let's look at the DR results. Okay, so here in gold, I've plotted all the people who were stable, who did not progress to PDR or DME. So over from the baseline measurements through 12 months. The blue are the people who progressed, who sometime during the study progressed to having PDR or DME. And what's on the vertical axis is the DR score. So you see a big difference even at the baseline between this group of stable subjects from this group of people who progressed. That's what you want. You want a big difference so you can tell the difference between them. Also, look at this slope. This is increasing. Here's the big difference. This slope is increasing at 0.1 units per month or 1.2 units a year. So these people are, the groups are even diverging by the 12th month. And this suggests that kind of annual screening or annual testing for diabetic retinopathy using the RETeval device could be useful, because over the course of a year, you kind of got a 1.2 unit change in the DR score, which is roughly kind of, the level of variability in the test is about 1 unit. So you can kind of see that you could get, a significant change with longitudinal measurements spaced at about a year. What about the best OCTA measurement? Here's the best OCTA measurement. So at baseline, here's where the stable people are, here's the progressors, and there's just not a lot of air gap. There's not a lot of white in here, right? This is really only a mediocre predictor of who's going to predict. What about looking over time? Well, not only is the slope not statistically significant, it's going the wrong way. It's making these two groups closer together, not further apart. So even the best alternative between OCTA, fluorescein, RETeval, and photography, if you start with people with moderate NPDR, there really is only one choice if you want to try to do any predictions in that first year time frame. Okay, so I've talked about result quality in comparing the RETeval device to other methods for detecting diabetic retinopathy. And I've tried to say that the result quality is superior in head-to-head longitudinal result measurements. That's the best gold standard there can be, is a longitudinal measurement. There are other things to compare as well. One is kind of, well, what's the cost per test? Well, RETeval costs about 14 bucks. The competition, photography and telemedicine cost about $40 per patient, as described in this analysis of that in the journal Connecticut Medicine. The RETeval device is handheld. These things are kind of 60 pounds with laptops. How much time do you have to train them? RETeval training is really straightforward, maybe 15 minutes. Photography, there's kind of hours or certification processes. It's an ordeal to get trained. Do you have to dilate? No, in fact, you don't want to dilate for RETeval. It makes the test faster. You don't have to wait for dilation. Easier for the patient. Can be done in more places. You don't have to worry about Oh, well, I'm going to dilate it. Do I have to worry about, you know, a spike in intraocular pressure that happens, you know, occasionally? Well, in the competition, if you don't dilate, you're looking at a 20 to 35% failure rate. And then that only compounds this cost. This is the cost of this test, not including the cost of these failure rates that then have to get retested somehow. Even with dilation, you're kind of in a 10 to 15% failure rate. How long does it take to do the test? Maybe 3 minutes for the RETeval, and 10 to 15 minutes depending on how many pictures you take. And of course, that's after you've dilated. And the instrument cost is maybe 2 or 3 times more expensive. And this device is easy enough to kind of go wherever you want the patient to be tested. All right, so that's a review of the clinical evidence for the RETeval device in detecting diabetic retinopathy. Let me move on to talk about the changes in reporting for firmware 2.11. And in general, we've made 5 changes for this protocol. In the United States, we changed the name of the protocol. It used to be named 28 Hertz ERG and Pupil Response. We've renamed it DR assessment. And in the US, we also added the DR score. Kind of everywhere, we added photographs of the eye to the report. We now have operator selected limits for the DR score. In previous versions outside the United States, they were kind of incorrectly named as a reference interval. Reference interval really only talks about normal people. So it's now correctly named as a decision limit or operator selected limit, and the operator is given the opportunity to set their own limit the first time the protocol is used. And finally, reference data has been added to kind of the DR score and all the ERG and pupil response data that's collected as part of the test. So this is what the report formats used to look like. So in 2.10, the US version is showing reference data, as you can tell by the green highlights and like the little I-beam, and this bar showing that it had what's called a two-tailed reference data, where you can be too big or too small. It's colored red. In the international version, we had the DR score shown with an operator selected limit, but we didn't show any reference data associated with it. So now we've combined that for the 2.11, everybody gets the same protocol. And what have we done? We've added photographs of the eye, we have the DR score, we have operator selected limits, which is color coded to help you interpret it quickly. We have reference data for the DR score, and we have reference data shown for the ERG and the pupil data. And you might also see that the reference data here has only red on one side rather than red on both sides. So we have red, on the right side for time, and the left side are small amplitudes in pupil ratios. So as I just talked about, kind of red on one side or the other side, for a reference interval, if you say have a 95% reference interval, which is the common thing to have, if this is the distribution, if one of these is the distribution of people with normal vision, which 95 do you take? Do you take the middle 95% and have kind of, colored red for the atypical high results and atypical low results? Or do you say, no, I'm going to take my 95% to be over here and care only about low results being flagged as abnormal or as in the danger zone, or maybe this one. So, which one of these things? These are all 95% reference intervals. There's kind of 2 versions for one-tailed or 1 version for two-tailed. As a two-tailed reference interval, you might think of something like blood pressure, where high blood pressure is bad and low blood pressure is bad. For a one-tailed reference interval, you might think of something like a cancer marker for our blood test, where, no cancer marker is, you can't be too low in a cancer marker, but being too high in a cancer marker is definitely bad. So yeah, that's kind of examples of where you would use one-tailed and two-tailed in other clinical aspects. Starting in 211, we use one-tailed reference intervals because only long times for ERGs, small ERG amplitudes, small pupil responses, and large DR scores predict disease. So not only for this DR assessment test, but for all tests in the RETeval device, we're using these one-tailed reference intervals. So here are some examples for diabetic retinopathy. So on the x-axis here, I'm plotting an ERG timing, flicker time. And on the y-axis, I'm plotting the percent of subjects who needed an ocular intervention, an eye surgery for diabetic retinopathy in 1, 2, or 3 years after the measurement. And as you can see, if you increase the time, you get more and more likely to have an ocular intervention. So this is a classic example of a one-tailed reference interval. Faster times are always better, no matter how fast you are, but you can see where we color red now is the part where this is the danger zone for having an ocular intervention. So this is time. What about the others? Well, here's amplitude. So if the amplitude of the ERG gets smaller and smaller, you start to get in danger of having an ocular intervention for these diabetic retinopathy patients. What about the pupil response? Remember, this is the pupil area ratio for an 8-fold increase in brightness. So if you have a 2-fold change in your area, you're pretty healthy. But if your pupil doesn't change size, when the brightness of the light increases by a factor of 8, you're in danger of needing an ocular intervention in the next, couple years. And finally, the DR score. As you increase the DR score, you're in danger of having an ocular intervention. And for all 4 of these cases, the curves only go up in one direction, which is why we use one-tailed reference intervals. So maybe to clarify exactly how we show this on the report, here's an example of an ERG. Shown at the bottom here is when the flashes of light happen. So from this flash of light, we get this peak. From this flash of light, we get that peak. And if you look here at the gold ERG waveform, we have this gold rectangle, which is the middle 95% of the reference interval. So this is the two-tailed reference interval. So you could be atypical by being too fast, too slow, too big, or too small. And we're showing that 95% reference interval in a two-tailed manner just so we can see who's atypical. That the numbers for those things are shown here, and we also show the percentile of where you are. But the colors on the plot aren't two-tailed, they're one-tailed. So if you're abnormally fast for someone with normal vision, well, we know that faster is okay. You might play, competitive ping pong because your reaction times are so fast. You're colored green. You aren't colored red. Red is reserved for the side, which is the side in which the disease lies. Okay, so let me talk a little bit about operator selected limits or clinical decision limits versus a reference interval. Reference intervals are only made with people from healthy subjects. So if this is like a distribution of ERG results from healthy subjects, you might use this one-tailed interval for setting a cutoff point, and you would have a specificity of 95%. How do I know I have a specificity of 95%? Well, specificity is the probability that for a healthy person, you tell them you're healthy. And that's exactly what the reference interval is. 95% of normal people are in the 95% reference interval. So your specificity is 95%. But what about sensitivity? Well, it depends. Are the diseased people over here? Are they over here? You don't know. So A reference interval only talks about what you know about healthy people. If you want to talk about healthy people and diseased people, then ideally you have a clinical decision limit or an operator selected limit. Because there you can see perhaps the diseased people are way out here. In case they're way out here, then using this as the cutoff might not be the best point because you're classifying all these healthy people as diseased. Maybe the best point would be here. So this could be a better clinical decision point or operator selected limit. What happens if the disease distribution, you don't have that good of a test? Maybe your overlap is like this. Again, maybe the 95% reference interval isn't the best place to do the cutoff. Maybe you would choose it to be here so you could have equal sensitivity and specificity. So that's why you might consider, and that's why we provide not only the reference interval, but the operator selected limit. And depending on kind of, your clinics or your area's propensity to wanting to classify people as diseased when they're inappropriately or classifying people as healthy inappropriately, whatever trade-off you want, you can select that operator selected limit. So how do you set the limit? One thing in this version is that you get the opportunity anytime to change it, but the first time you run the test, it'll make you choose your operator selected limit because we want to make sure this is what your doctor, your physician wants to choose it to be. So there have been 4 published publications. There are the 3 cross-sectional studies I said, and the 1 longitudinal study has been published. The other one is still in preparation. The results I showed you were from a talk at a conference right before COVID closed everything down. And everybody suggested their own operator selected limit. So how do you choose among these 4 limits or any other limit? Well, I recommend choosing the longitudinal results. I recommend the 23.4. And that's because I just put a lot more weight in longitudinal trials. Things generally get more obvious with time. That pregnancy test that you took, right when you think that you might be pregnant and you get the ambiguous result, well, wait 3, 4, 5 months and you'll know for sure. Things get clearer with time. Also, the other issue with the nice thing about the longitudinal studies is like this one, compared it to something you actually care about. Who's getting a treatment? Who's bad enough to be treated? In cross-sectional studies, you're comparing to other methods which are then predicting who needs to be treated. So you're kind of one step removed. In fact, the ETDRS study, I'm going to get the number wrong, I think it was publication 11, showed that even high-risk PDR subjects have only an 18% chance of severe vision loss in the next 5 years. So, even the original studies showed that maybe there could be better ways to detect diabetic retinopathy or the needing to treat diabetic retinopathy than photography. And that's why I like the longitudinal studies. Okay, so that's the changes to the reporting for RETeval 2.11. Let me just go over a few practical issues in using and interpreting the results. First, what do you do with those pictures that we put on there? Well, one thing you can do with those pictures is check the electrode position. Taken from the user manual, the sensor strip placement should be in line with the center of the eye when the patient's looking straight ahead and with 2 millimeters down. You don't want it too close to the nose. You don't want it too far away from the eye in either temporal direction or below or down. So here's some examples from a clinical trial where these, I classify all these as good positioning, even though there's obviously some variability, but I think these are all kind of good. They're all lined up, they're all pretty close to the eye. Even this one, you can see just a little bit of the edge of it, it's not too far away. All these I think are kind of good enough. Where are some bad ones? So here are some bad ones. These I think are all too nasal. So you can see way too much of like the whole sensor strip is going nearly to the other edge of it. This is going to cause reduced ERG amplitudes, and it's going to be erroneous because the operator just placed the electrode wrong. And here's some examples where it's just too far away from the eye, too inferior. You can't see it at all. I can't see it at all. Not only can you not see it at all, you can see a centimeter of skin that's not having the electrode. Here, maybe a centimeter of skin, and maybe you can see a little bit of the electrode. This one I think is also a touch too far away. And every so often, you'll see this crazy result where the electrode is on upside down. You see this end has this little black icon on it. No black icon here. The electrode's on upside down, which makes the ERG upside down. Another thing you can look at for this protocol is looking for a dilated pupil. Remember, the DR score partly depends on the pupil response. And how do you get an unresponsive pupil? Well, there's two ways. One, have vision-threatening diabetic retinopathy, or two, artificially dilate them. So you want to make sure that they haven't even put in the dilating drops before the test. So here's some examples of what I call good pupil responses. Even though some of them are quite small, you can still see a little bit of motion in them, which kind of indicates that, yeah, it looks like it is a real thing. You can also look at the diameter. That's only 2.5 millimeters. This larger one, you can see not only do you see motion, it's 2.5 to 3.5 millimeters. Not a very big pupil. These subjects aren't dilated. When should you suspect artificial dilation? Well, if your pupils are above 5 millimeters, like this is hovering around 6 millimeters, and they're like totally flatlining, except maybe a little blip here, these all, I suspect, artificial dilation. So if you suspect artificial dilation, then of course you wouldn't want to put weight on the DR score in your clinical decision process because it's being affected by this poor pupil response due to artificial dilation. One other caveat I can bring up is, since we have operator selected limits and 95% reference intervals, there is the opportunity for these to disagree, and you get different answers. For example, this subject had a DR score of 22. The operator selected limit in this case was set where, well, this 22 is within the limits. But what's the 95% reference interval? 95% reference interval ended at 21.6. This is the 99th percentile. So what do? You have two measures and they disagree. Well, there's kind of two reasons for disagreement. One is the reference interval, as I described previously, is built only on healthy subjects. In fact, the reference interval here was built on 128 healthy subjects. And that's different than the decision limit, which was based on people with diabetes with and without vision-threatening retinopathy. And those two classifications, and in the longitudinal trials of who's going to progress, those decision limits were made by looking at diseased people and healthy people. So that's a reason why they could disagree. There is another reason that they could disagree, and that is the DR score is age corrected, and it was age corrected in the original MA trial from about 78, I don't remember exactly, 75, 78 subjects with diabetes, but without retinopathy. And the age correction for the reference interval was done with people without diabetes. So, and those two age correction factors differ. And maybe they differ because they were just two different populations. One had 75 or so people, one had 128 people. They were different populations. But it could be that one group had diabetes and one group didn't have diabetes. It's hard to know. But the average age for kind of all the tests, all the 4 published studies, was about 60. And if you look at the reference data, age corrected age 60, this is what you get. So as you can see, the score of 22 is here, this cutoff point of 22. And yeah, there isn't a lot of people in that reference data out this far, 1%. But if you look at different ages, then you'll get different answers. So here is the results from an 80-year-old, 60, 40, and a 20-year-old. So as you can see, as you get younger, the reference data, the reference distribution shifts to the right, which means that a 20-year-old is more likely to have a higher score than an 80-year-old based on the age correction. So what does that mean for you? So if you're testing like a teenager or someone who's young, maybe in their 20s, and they're healthy, and they get a red DR score, based on this difference in age correction and knowing that all the studies are around 60, they're probably not at risk because they're young and because they're young. Now, if you have an older person and they're healthy with a red DR score, these are the people you need to watch carefully. Now, if you don't have someone with that level of extreme age difference from the average age study of 60, you have someone who's, in their 30s or higher, then, probably I favor, looking at the operator selected limit because that was intentionally set to do the balance of sensitivity and specificity. Okay, another possible issue is treating or following unilateral disease. So, as mentioned before, the DR score uses the best eyes ERG and the worst eyes pupil response. And that might not be the eye you're concerned with. Diabetic retinopathy is almost always a bilateral disease. But maybe you're using this protocol for a different disease, or maybe in your special case, one eye is more affected than the other. You only treated that eye, and you want to follow the treatment. Well, in that case, you might want to not use the DR score portion of the test and concentrate more on the individual eye of concerns, ERG and pupil response data, or at least be aware of what's going on in kind of both eyes. So, in summary, the DR assessment test with the DR score has been clinically validated in multiple cross-sectional and longitudinal studies for the detection of vision-threatening diabetic retinopathy and the prediction of diabetic retinopathy disease progression. We have a new report format in version 2.11 that makes it so you can have this quick assessment of the subject by looking if the DR score is within or outside those operator selected limits. There's additional comparison to reference data from 128 people who are visually normal. And you have this drill down capability for the ERG and the pupil response with reference data. So you can say, well, maybe this person's abnormal. Well, what's abnormal about it? Am I concerned more because the ERG timing is off, or is it more of a pupil response is off? So you have that drill down capability, and you have the ability to do your own quality control testing or checking with these photographs of the eye, where you can kind of see, is the person dilated? Are they looking in the right direction? Do they have, is the sensor strip in the correct position? And you can also look at the pupil response to see if they're dilated. And if that, I appreciate your time and your attention. And I think the DR assessment test can really save a lot of sight for people suffering from diabetes. Thank you.